Y en interés del tiempo paso ya a la presentación de nuestro último speaker. Our last speaker is today also an honor to have him here. It's Giovanni Guaraldi, and I'm going to switch to Spanish for the bio sketch. Giovanni Guaraldi es profesor asociado de enfermedades infecciosas en la Universidad de Módena y Reggio Emilia, en Italia, donde hizo sus estudios de medicina y posteriormente su residencia en la Escuela de Medicina Tropical de Liverpool, UK, y en el Jackson Memorial Hospital en Miami. Forma parte de la Task Force de la Universidad de Módena dedicada al desarrollo de investigación en países en desarrollo, con lo cual tiene cooperación internacional muy importante. Y desde el 2002 ha comenzado un programa de trasplante de órgano sólido en personas con infección por VIH y lleva personalmente una cohorte de más de 80 personas con trasplante de órgano sólido con infección por VIH, lo cual es realmente muy importante. Desde el 2000 es el head, el líder de la clínica metabólica para personas con VIH en Módena, que es realmente un modelo y una clínica pionera, donde funciona como centro de referencia y ha valorado a miles de pacientes con complicaciones metabólicas y probablemente es uno de los expertos mundiales a nivel de la complicación metabólica en general de las personas con infección por VIH. Desde el punto de vista científico es autor de más de 500 publicaciones como autor o coautor indexadas en PubMed. Y desde el punto de vista de sociedades científicas, que esta es una mesa conjunta, desde hace muchos años es miembro del panel de comorbilidades, es actualmente el chair, el head del panel de interacciones farmacológicas, y es un gusto tenerlo aquí con nosotros. I think it's going to be really interesting to see your presentation. Exactly, the title is NAFLD or MALFD in persons with HIV topic. How to prevent, how to treat, investigational agents and practical recommendations. Y creo que va a ser muy interesante la discusión final. Muchas gracias, Giovanni.
So, thank you so much for this kind invitation. I'm happy to share with you some data that we try to generate in modern HIV metabolic clinic and try to, let us say, contribute a bit regarding prevention and treatment of NAFLD and MALFD in people living with HIV. These are my disclosure, and I think that Jürgen already set the scene just to say, well, NAFLD is frequent in people living with HIV. Maybe it's more frequent than the general population because apart from classical factors, there may be factors that are unique in people living with HIV. Let us go through and try to set the scene from a clinical point of view. I will introduce now Paolo. Paolo is a patient living with HIV. I've been taking care for the past 20 years. I diagnosed overt AIDS 20 years ago, in which at that time Nadir CD4 was 55 cell. And you can see that now he has restored the number of the CD4 cell count. Nevertheless, the CD4-CD8 ratio is still low. Regardless, this is more than 15 years. It's got undetectable viral load. And you can see that in the past 20 years, he developed many comorbidities, hypertension, lipodystrophy, dyslipidemia, osteopenia, and definitely obesity. Okay, let me say that I had to struggle a lot with regard of finding out appropriate antiretroviral therapy. My concern in this situation was not efficacy because he had no drug resistance, but rather how to cope with the ongoing metabolic abnormalities that was coming out. And exactly in 2017, something happened because whenever I switched him to INSTI, he developed obesity. But this, according to Paolo's interpretation, was something that was very much at the same time in which he got divorced and totally his lifestyle changed. He turned to be sedentary, while before he was a very, let us say, active person, and he started drinking too much. I believe that all this contributed to a very low quality of life that we routinely assess. At that time, AQ5D, 5L was 85%, and regardless his relatively young age, he actually had a pre-frail status. And so this is a picture of Paolo in 2007. At that time, his BMI was 24, and this is the presence of Paolo now. You can recognize that presumably two concurrent phenomena occur. On one side, he already had a lipodystrophy with central visceral adiposity, but definitely he developed a weight gain on the top of that. And of course, I'm worried because now I know that he's got NAFLD. Actually, I can tell you that he's got NASH because he also received a biopsy. And so the question is regarding the ongoing debate. Should I diagnose him as NAFLD or rather MALFD? You know, it's so difficult to have an appropriate identification of the amount of alcohol he's taking, okay? And so presumably, I think that the better way to define the association between his fatty liver disease and the complex metabolic derangement that are occurring in Paolo is definitely to define as MALFD using overweight as a criteria. Luckily, Paolo is not yet diabetes regarding he's got insulin resistance, but I can say that also multiple metabolic risk abnormalities are present. But should we go into the MALFD criteria just because Paolo is obese? Well, actually, in this study we did together with Giada Sebastiani, we were able to demonstrate that maybe in HIV there's a unique proportion of lean individuals that appear to be higher than the general population, in which also in person with totally perfect BMI, up to 25%, may have a fatty liver disease. And so once again, I believe that the point to screen for NAFLD is not just because you are overweight, as most should do in the general population using a public health approach. Given that, can we compare NAFLD and MALFD and try to see if there's different predictors? And so this is a study in which we join the Modena cohort, the Palermo cohort, and the Montreal cohort, and we ended up to having a cross-sectional evaluation, almost 2,000 people. We wanted to see to what extent NAFLD and MALFD were overlap, and it is the vast majority of this. Nevertheless, you can recognize that there is still almost 7% of people that would have NAFLD but no MALFD, and actually few individuals that have MALFD, especially you can see also lean people that have MALFD but not NAFLD. Altogether, NAFLD prevalence was 36% and MALFD 33%. But let us go to identify which are the risk factors. Let us start from the last part, that is the overlap. This is the vast majority of our people, and you can see that male gender, that the duration of HIV, high triglycerides, and BMI are the driver for all this condition. Nevertheless, if we go into the NAFLD, exclusively NAFLD part, you can see that low BMI is protective, as well as high BMI is, of course, a risk factor for NAFLD and obese individuals, as well as fibrosis, and this is something I will go back to. With regard of lean MALFD, you can see that HIV duration appear the only predictor of this condition. But of course, this is cross-sectional data. We believe that what is important is just to see the evolution, and in particular, what is the progression of all these conditions. And so actually, we were able to find a subset of 888 individuals in which we had at least two FibroScan evaluation 2 years apart, and I don't want you to get into the single situation, but in this alluvial plot using a Markov model, you can identify that the vast majority of transition, that is from non-MALFD to MALFD and from MALFD to fibrosis, actually occurred in the people who's got MALFD with high BMI. And this is true both for the progression to MALFD and progression to fibrosis. I would like also to underline the fact that with regard of reversion of this situation, you can see that the reversibility appeared to be higher in the lean MALFD, and with regard to fibrosis reversibility, these appear to be higher in MALFD with diabetes. And so somehow this study goes through this theoretical model that Wong and Jeffrey Lazarus published just a few years ago, 1 year ago, in which somehow they put as a variant on one side the metabolic burden, on the other side the risk of complication, and you can see that MALFD MALFD alone is in fact the higher proportion of situation in which you can identify complication regarding the metabolic derangement, somehow suggesting that the moving from NAFLD to MALFD diagnosis is something that may better qualify the situation of higher metabolic risk factors and maybe mortality in the future. And so a few years ago, actually, I was trying to push this model to say what will be the possible consequences. And so is the consequences that are just related to the fibrotic stage of the disease, or rather per se the identification of MALFD as a metabolic condition will help us to identify comorbidities, but also, let me say, cancer, as well as maybe geriatric syndrome and aging process. And so in this study that we did comparing NAFLD and non-NAFLD and fibrosis and non-fibrosis, we identified that diabetes, hypertension, dyslipidemia, and cardiovascular disease were more prevalent in people with NAFLD and not just in people with higher fibrosis, somehow underlying that the metabolic association with NAFLD is correlated with comorbidities. And this may be particularly true with regard of cardiovascular complication. Is interesting that many times we believe that the metabolic derangement is just something affecting the coronary heart disease because of development of atherosclerosis, while in fact you can identify that there are other heart condition, like for instance congestive heart failure, but also cardiac arrhythmias that may be associated with this condition. And in fact, there are cohorts that demonstrate that there is a relationship between non-alcoholic fatty liver disease and cardiovascular disease in people living with HIV. What we were interested, also because this is a major topic of our studies in modern HIV metabolic clinic, was the association between NAFLD and frailty. You know that frailty is not a comorbidity on the top of the other, but is an umbrella condition that highlight the vulnerability of an individual, depicting the biological age of the individual. And so actually in this cohort in which we identified that people with NAFLD had in fact several comorbidities like diabetes, obesity, vitamin D insufficiency, and neurocognitive disease, what we were impressed is to see that almost 70% of people with NAFLD and fibrosis were frail. And actually, we identified that NAFLD with fibrosis predicted frailty 3 times better than multimorbidity, and we think that multimorbidity is the driver of frailty. On the contrary, here, the presence of NAFLD was much higher than that. Well, let us move now with regard of how to treat this condition. And so these are American Association for the Study of the Liver guidelines, and they suggest us that there's 3 major pillars in order to first-time treatment. This is weight loss, exercise, and bariatric surgery. With regard of weight loss, it really depends on how much you can decrease body weight in a person who is overweight or obese. Let me say that we still have a proportion of people who are lean, and weight loss may not be sufficient. And so our approach is not just to consider BMI, but also to consider the body composition and try to identify, for instance, what the contribution also of sarcopenia sarcopenia in this situation. And we know that sarcopenia have a significant impact, for instance, in insulin resistance, that is the metabolic driver that is mainly associated with non-alcoholic fatty liver disease. Nevertheless, with regard of the vast majority of people who are overweight or obese, it really depends how much weight you are able to diminish in order to obtain an effect that is just with regard of the fat, or even being able to revert the inflammatory or even the fibrotic stage. Because actually, if your weight loss is more than 10%, you can even affect the fibrosis stage in your individual. And this may be particularly true in the many patients, as Jürgen was saying, that we follow in waiting list for transplantation, in which hopefully this kind of intensive intervention are really needed. The second part is regarding to exercise. Actually, our concern is that the diet without exercise will not be sufficient. I already told you the association with frailty, for instance, and to what extent frailty is associated with sarcopenia. And so actually we know that exercise alone can reduce steatosis, but the impact is really whenever exercise is together with weight loss. Bariatric surgery is something that is just starting in the setting of HIV. I've got some concern in order to avoid people who already have NASH because the outcome may be worse. With regard of EAS guideline, they get much more in detail, and the point here is really to have energy restriction. Of course, this means that you must eat less, but also you must have an appropriate diet. I don't have time to compare all the studies that really compare the different diet. What I can tell you is that ketogenic diet seems to work very well because maybe is the most powerful in weight reduction. But in the long term, all the studies seems to demonstrate that the Mediterranean diet is still the best to be suggested in our individual, and presumably the less, let us say, difficult to perform in the long term. Let me say an important issue is with regard of fructose intake. We know that fructose is added as a sweetener in many beverages, and so it's very, very important to give detailed information about not to use anything out from water in these patients, but also try to stress, for instance, that coffee drinking appeared to be somehow protective in this individual. Of course, whenever we wanted to tackle NAFLD and its progression to fibrosis, we needed to think that there may be HIV-induced, art-induced, and HIV patient phenomenon. And so actually, if you go to the bottom of this, you can see that for each, we can identify what are the possible components that may contribute to the lipid metabolism, to the inflammation issues, as well as the fibrosis. And you can see that, for instance, with regard of lipids, HIV may have a direct situation because of VPR gene is induced in adipocyte hypertrophy. But we know that many antiretroviral regimens play a role with regard, for instance, of insulin resistance, like boosted PI, but also oxidative stress with regard to first-generation NRTI. But of course, now the topic is regarding the weight gain. With regard of patients, we know that lifestyle, but also genetic factors play a major role. With regard to inflammation, again, you can see that there may be VPR gene-induced macrophage recruitment in adipose tissue, somehow introducing also an inflamed fat liver. And as well as we know that with regard of antiretroviral therapy, we know that inflammation may have been induced by mitochondrial toxicity, especially induced by first-line NRTI, and we know that this may not be fully reversible even many years after that. Of course, we may also have impact with regard of the fibrosis stage, maybe by chronic inflammatory state regardless, undetectable viral load and immune activation, but also cumulative exposure to DDI's drug, in particular didanesis, has been associated with fibrosis outside from the metabolic component, and we know that there's a genetic component regarding that. But are there drugs that may affect all this? And actually, the pipeline has been quite long, and there were many drugs that appear to come to the market shortly, but actually at the end fail what was the FDA requirement. And you know that FDA really requires the improvement in fibrosis first, without worsening of NASH and vice versa. I'm a bit concerned that this may be too restrictive because of what I showed you before regarding also the impact of liver steatosis. But what we were worried is that in all these studies, actually people living with HIV were excluded. And so that was why some years ago we wrote an opinion paper on hepatologists in which and the group was called Shiba, and we were worried on the fact that people living with HIV should not be excluded. And this was something that we have observed also in the past with direct active aging for hepatitis C, in which people were initially excluded. In this table, we asked Katia Martolini to show what were the potential risk of interaction with regard of all the drugs in the pipeline, and you can see that in fact there's nothing significant, and we need to ask that also drug company introduce people living with HIV as a subpopulation where to study these drugs. These are the very few studies that actually looked for agent that may impact either the metabolic or the inflammatory or the fibrosis stage. You can see that the numbers are very small. I would like to go through these because actually they didn't appear to be effective with regard at least to the fibrosis compartment, and this is Aramcol, but interesting pioglitazone, that is an approved drug for diabetes, and actually I use a lot as an insulin sensitizer. What we know is that in this very small study by Giada Sebastiani appeared that vitamin E can be an initial, let me say, bridge therapy towards something that need to be better than that in the future, because of the fact that we know that vitamin E may be also associated with long-term toxicity, and especially we need to screen for prostate cancer in men. What I think is the best trial done so far is really the effect on tesamorelin on fatty liver disease. This is a beautiful study by Strien Grismund that was here yesterday, and tesamorelin was in fact able to reduce not just the fat but also the progression of fibrosis, and this also improve systemic inflammatory as measured by C-reacting protein. Something that was stopped in the development is Centriviroc. You know that this is very similar to the Maraviroc that we've been using in people living with HIV. And in this study, actually, there was a benefit, but actually it failed to demonstrate any improvement with regard of the fibrotic stage of the disease. I believe that what is in the future is really the use of GLP antagonist. These increase insulin resistance, decrease appetite, delay gastric emptying, and most of all are the most important agent to reduce weight. And you can see that in the general population, as soon as you look at the treatment of diabetes on the top of metformin, these drugs are really effective to reduce all the metabolic but also the the fat component, not just in the subcute, but also in the visceral area. And so this is one study that was able to demonstrate that semaglutide is effective and will be the most important agent in the future to treat both steatosis and fibrosis in people living with HIV. But what about the management of antiretroviral therapy? And so you see that in my concern, there's some drugs that are going to be studied, some failed, but what we really need is to build cohort to be ready whenever we will have trial to introduce people living with HIV, and we ask to introduce people living with HIV. What we know is that drugs that we necessarily use for the treatment of HIV should have an impact. And we know, for instance, that NRTI may be implicated, as I told you before, with regard of mitochondrial toxicity. Are there data about long-term mitochondrial toxicity? Do we need to get out from NRTI in the long term, or rather hypertriglyceridemia, lipodystrophy, and hypoadiponectinemia? With regard of PI, they are definitely associated with insulin resistance and dyslipidemia. Efavirenz is associated with hypercholesterolemia, and of course weight gain is, INSTI is associated with weight gain. Jürgen already showed this study that we presented at Glasgow, and what I want, and so Jürgen stressed the fact that apparently INSTI with TAF was associated with an increased risk of progression from non-NAFLD to MALFD. But what I would like to stress here is that INSTI plus TAF are not associated with regression of this situation. And so go back to the case of Paolo. Paolo increased a lot his weight when he switched to INSTI. Nevertheless, this does not mean that now he will not be able to revert in this situation. We know that in most of the cases, the weight gain affected just the first year, starting INSTI, but after that, the trajectory is very similar to the aging trajectory and concordant with the environment where you live. And so the point is that I'm not really sure that the future will necessarily be into switching back or finding new drugs, but also to promote better lifestyle. I think that this guidelines, that is AX guidelines, has already been presented by Maria Luisa before, but let me go through a case example. This is a guy that actually has got totally normal liver transaminase. He's got dyslipidemia and hypertension, and you can see that what we need to ask is to have a screening using an algorithm. And so you can see here that FIB4 is 0.98 and NFS is 0.33. If you see what the guidelines really suggest us is to have an evaluation for NAFLD, and in fact you can see that he's got severe steatosis, but F0, F1 fibrosis. And according to this, what we know is that this probability to evolution is still low. What I need really to concentrate in this individual is to have anyhow a weight loss and manage his cardiovascular disease. On the contrary, I have this same age, obese individual. Again, in this situation, liver transaminase are normal. He's got definitely much more complicated condition, and FIB4 now is positive, and stiffness is high, actually 17 kilopascal, as well as severe steatosis. In this situation, I need to consider this guy into, let us say, a referral to a pathologist and possibly get into a court where drugs should be used. Just to slide to say, put this in the context to a public health approach. We are speaking about a condition that affects one patient out of 4 of the general population. And so the point is that moving from NAFLD to MALFD is also something that try to push the diagnosis and the initial treatment into the general medicine somehow. And I believe that there is a role of primary health care in order to screen and in order to even treat. The point is that with regard of patient representative, the change from NAFLD to NAFLD may really improve the reduction of stigma and actually reduce also confusion and try to have a better attention in the public in the public health sector in order to screen and to treat. And for this I conclude, and I wanted to acknowledge all the people in University of Modena and McGill University and all the Shiver group that helped me to put these slides together. Thank you so much.
It's so big that apologies for giving you a tight time.